Hello my dear students. Well, this is Dr. 𝗲𝗵𝗵𝗺, your original guru of biochemistry. In this video, we are going to discuss on dyslipidemias, right? So before starting up with the discussion of dyslipidemias, you need to have a solid knowledge information about what are the different lipoproteins. Because whenever we study the metabolism of lipids or fats, we study them under two subheadings. Because lipids are non-polar, they are not soluble in water, so they will always require a carrier protein to be transported. So we always categorize we always study the metabolism of lipids under two subheadings. Now the question arises, what are the different type of lipoproteins? Okay. Because now in this video we will be discussing about the dyslipidemias. So what happens in the body when the concentration of any lipoprotein increases, or what happens to the body when the concentration of lipoprotein decreases? So what are lipoproteins? Lipoproteins, again, if we talk about, they are the complexes of protein and lipid. So just the protein part is known as a apoprotein. Okay, and this overall gets, it forms lipoproteins. So always remember there are four types of lipoproteins, principal ones. The chylomicrons, then VLDL, very low density lipoproteins, LDL, low density lipoproteins, and HDL, heavy density lipoproteins. When VLDL is converted into LDL, IDL is also produced, which is intermediary density lipoprotein. Okay, so you have to understand the difference between lipoproteins and lipid. Lipoprotein is the one which is associated with the apoprotein, and lipid is like a lipid or a fat molecule. So if we talk about chylomicrons, chylomicrons have maximum exogenous TGs, whereas VLDL has maximum endogenous TGs. Right. So triglyceride are the fats and lipoprotein is chylomicron, or lipoprotein is VLDL. So VLDL lipoprotein has maximum concentration of endogenous fat. LDL has maximum cholesterol. Right, and HDL has maximum protein. Or HDL has one more important function to perform. It is responsible for a reverse cholesterol transport, which I have already discussed in my video on the metabolism of HDL. Cholesterol transport, right? So I can say that the lipids are triglycerides and cholesterol. But if we talk about the lipoproteins, these are the 4 or 5 main lipoproteins. And what are these dyslipidemias? Dyslipidemias are a class of disorder related to the lipoproteins whenever there is a defect in the enzyme or defect in the receptor. Okay. So we can categorize these dyslipidemias, and Frederick was the scientist who actually gave a detailed classification of these dyslipidemias. So they are basically of two types. One is hyperlipoproteinemia, right? And second is hypolipoproteinemia. hyperlipoproteinemias. Right. This hyperlipoproteinemias is further classified into two main types: primary and secondary. Detailed classification we study actually in medicine also. So here in biochemistry we will be focusing mainly on the primary hyperlipoproteinemias and the hypolipoproteinemias. So under primary hyperlipoproteinemias, there are 5 main types. So what happens here is, either there is an increase in chylomicrons, right? So it will lead to hypertriglyceridemia, or there will be increase in TGs. In second, there will be an increase in cholesterol. So it is hypercholesterolemia. And in third category, it will be increase in both triglycerides and cholesterol. So when there is increased concentration of TGs, type 1. When there is increased concentration of cholesterol, type 2. And when there is increase in the concentration of both, it is type 3. In type 4 and type 5 also there is increased concentration of the triglycerides. So this HTG stands for HTC-HC. So this stands for hypertriglyceridemia. HC stands for hypercholesterolemia. Right. So let's start up with what is type 1, what happens in this type 1 type of hyperlipoproteinemia. Now we can simply say that hyper means the concentration of lipoprotein will increase. Hypo means the concentration of lipoprotein will decrease. Now what are the factors which lead to the increased concentration of the lipids, or what are the factors which can lead to the increase in the concentration of the lipoproteins? That is what we are going to discuss in this video. So first of all, let's start up with type 1. The other name of this type 1 is familial hypertriglyceridemia. Now see what happens. What is the reason for this defect? Now the reason for this defect is that either lipoprotein lipase enzyme is absent, deficiency of lipoprotein lipase, right, or there is a defect in Apo C-II. And we all know that this Apo C-II is a very important apoprotein which is required for the transport of chylomicrons as well as VLDL. Okay, because Apo C-II का function क्या है? Apo C-II will always activate LPL. अब the problem here in this type 1 disease is that LPL is also deficient, or there might be a defect in Apo C-II. So what will happen if we talk about what are the lipoproteins which will increase? So if we talk about the lipoproteins elevated, because those two things can be increased, lipoproteins or the lipid. So if we talk about lipoproteins, Apo C-II is an activator of LPL, which is required for the transport of chylomicrons and VLDL. So chylomicrons and VLDL will be elevated. And coming over to the lipid, triglycerides, TGs will be elevated. And if we talk about the concentration of cholesterol, most important, here cholesterol level will be normal. Normal cholesterol. And that is why it is also known as familial hypertriglyceridemia as well as hyperchylomicronemia. Very important. So we can call it as FHC also or FHTG also, whatever. Okay. So this is the most important point which you have to remember under type 1, that the lipoprotein lipase or Apo C-II is defective. So Apo C-II, since it is an activator of this lipoprotein lipase, so the lipoprotein which will, that means there will be a problem in the circulation of chylomicrons and VLDL, right? So obviously there will be increased concentration. Now the question is, when chylomicrons and VLDL or TGs increases, the most important feature here is that the plasma, or you can say it will be whitish in color or it will be turbid. Why it will be turbid? Because we call it as lactescent plasma, because of the increased concentration of TGs. We know lipids are not soluble. So it will appear in the form of whitish plasma, and if a patient, if we are keeping the blood for a longer time, so we will see after some time that whitish layer will come. So the most important thing here will be, what are the features? So features the most important one will be lactescent plasma. Which means whitish, white milky like appearance or turbid. Then due to the increased concentration of TGs, lipase is the enzyme which is affected, and we know whenever this type of condition occurs, whenever there is increased concentration of TGs, it will lead to acute pancreatitis. So patient will complain of the pain in the abdominal region. Why? Because of acute pancreatitis, the reason is there is increased concentration of TGs. So abdominal pain will be there. And another important feature here will be xanthomas will be there. Xanthomas क्या होते हैं? Xanthomas are basically deposits of these chylomicrons or deposits of these fats. And what kind of xanthomas are there in type 1? They are eruptive xanthomas. Right. And if we do the fundoscopy of the eye, one can see that there is deposition of triglycerides in the retinol, blood vessels, which is known as lipemia retinalis. So we can say that fundoscopy will reveal lipemia retinalis. Right. And if I'll just show you the picture of the xanthomas. The xanthomas will be having, these are eruptive xanthomas. You can see that. The eruptions are there. So this is a characteristic feature of hypertriglyceridemia, or we can call it as hyperchylomicronemia. And if you see there is a difference. If we talk about the lipoproteins elevated are chylomicrons and VLDL. We know that chylomicrons have exogenous TGs, VLDL have endogenous TGs. So lipid which is accumulated is TGs, but the cholesterol level will be normal. Okay, and if we talk about the features, we can detect white milky turbid plasma will be there, and the person will suffer from acute pancreatitis, because pancreatitis may, again if we talk about the enzymes which are diagnostically important, then this are lipase and amylase. Lipase, which is the most sensitive indicator of this. Then eruptive xanthomas will be there, and if fundoscopy of eye is done, it leads to lipemia retinalis. So this is our type 1 hyperlipoproteinemia. Clear? And this is autosomal recessive. Because if I am telling you, if I am not mentioning the mode of inheritance, it has to be autosomal recessive. If it is X-linked, I am going to mention it, or if it is dominant or recessive, I am going to mention it if it is different from the rest. Then next is type 2. Now type 2 mein I told you it is known as hypercholesterolemia or familial hypercholesterolemia. Right. So what happens here is, it is clear from the word itself, there is increased concentration of cholesterol. Now the question is that what leads to this? So defect is what? Defect is in the LDL receptors. LDL receptors are defective. And the most common feature of this is, it is autosomal dominant. Very important. So familial hypercholesterolemia is autosomal dominant. Now coming over to, since LDL receptors are defective, now we know that LDL का function क्या है? LDL is responsible for the transport of cholesterol. LDL is transporting cholesterol. That is what we have studied, that this LDL leads to the transport of this cholesterol to the peripheral organs. Now those LDL receptors are missing. They are not accepting it. So obviously there will be an increase in the concentration of cholesterol. Right? So if we talk about the investigation, so I can simply say that if we talk about the lipoprotein elevated, it will be LDL. Right? So lipoprotein elevated would be LDL. And if we talk about the lipid which is elevated, it will be cholesterol. And if we talk about TGs, TGs will be normal. So I can say that normal triglycerides will be there. So now if normal TGs are there, so the feature is more or less clear that the plasma will be clear. Because if there is excess of TGs, okay, then only the plasma will change. So here if we talk about the features, the most important one will be clear plasma. But here again accumulation will be there, deposits of cholesterol will be there. Now what kind of xanthomas will be obtained here? The xanthomas obtained in case of cholesterol increased concentration, it will always lead to tendon xanthomas. tendon xanthomas will be there. And इसमें the most important diagnostic feature here will be that Achilles tendon will be the one which will show the deposits of cholesterol. And inside the eye also there will be deposition of the cholesterol, which is known as corneal arcus. But here no pancreatitis. This is very important. So if we have to differentiate between type 1 and type 2A, this is basically type 2A. So in type 2A, we can simply say that ek to tendon xanthomas will be there like this, right? Jaise you can see here, deposition of cholesterol, which is clearly visible. Okay, so this is tendon xanthoma, and here we can say that corneal arcus will also be visible. So always remember, this is type 2A hypercholesterolemia, okay, which is autosomal dominant. And reason इसमें क्या है? Due to the defect in the LDL receptors. So obviously if there is a defect in the LDL receptors, the concentration of cholesterol is going to increase, because LDL is the one which is transporting cholesterol, right? Then we come over to type 3. Now type 3 is also known as familial 𝗵𝗵𝗵𝗺. Type 3 is also known as familial 𝗵𝗵𝗵𝗺𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵𝗵 happens here is, if we talk about the defect here, the defect is Apo E. Apo E undergoes mutation. Now, if we talk about the function of Apo E, it is required for, if we talk about this function, it is required for receptor mediated endocytosis, isn't it? And we know that what happens is, whenever this remnant chylomicrons and remnant VLDL, okay, this is say remnant chylomicron and this is a remnant VLDL, which is also known as IDL. It has, we know, 3 apoproteins, 1, 2, 3, 1, 2 and 3. Here Apo B48 is there, Apo C-II is there and Apo E is there. Here Apo B100 is there, Apo C-II is there and Apo E is there. And what happens here is the liver. Liver, which has a antenna shaped molecule which is going to accept this Apo E. Now this is Apo E is defective. So whose concentration will increase? Obviously the concentration of remnant chylomicrons will increase and remnant VLDL will increase. Alright, that is why it is also known as 𝗵𝗵𝗵𝗺lipoproteinemia. Why? Because IDL or VLDL is again we have studied in electrophoretic separation, it is a beta lipoprotein. VLDL is pre-beta, IDL is broad beta. Okay. So, and we call this disorder also as remnant removal disease. Remnant removal disease. Right? So, if we talk about, again, we will come to that thing, lipoprotein, which will be elevated here, and if we talk about lipid, which will be elevated here. So, if we talk about lipoprotein here, lipoprotein will automatically be remnant chylomicrons and remnant VLDL. They will increase. And if we talk about the lipid increase will be obviously the triglycerides. They will also increase. Along with triglycerides, cholesterol is also going to increase here. This is the basic difference between type 1, 2 and 3. In 3, there is increased concentration of triglycerides, there is increased concentration of cholesterol. Okay, so coming over to this, if we talk about the features here, the most important feature here will be the xanthomas. And if we talk about the xanthomas here, they will be tubero-eruptive, like grapes. Tubero-eruptive xanthomas or palmar xanthomas will be there. And the most important thing is they will be more likely, slight risk of coronary artery diseases will be there. So you can say slightly increased risk of CADs. Right. So this is type 3. Let me see if there is a picture of the xanthomas. These are the tubero-eruptive xanthomas. You can see that the size. So later stages may they become the like bunch of grapes, and on the palm also they will be there. So type 1 may there is increase in the concentration of TGs or chylomicrons, because chylomicrons always keep one thing in mind. Chylomicrons are the bulkier lipoproteins. Why they are bulkier? Because they are having exogenous TGs, and they are so bulkier that the amount of protein required to transport them is very small. Okay, and that is why they are the least dense in comparison to HDL. Same is the case with VLDL and LDL. Then comes type 2A. Type 2A may the defect is in the LDL receptors, so automatically you can say the level of cholesterol will increase but TGs will be normal. In type 3, the Apo E receptor is defective. So liver cannot read, liver cannot accept that which is bearing these remnant VLDL and remnant chylomicrons. So their concentration will increase. And in this, so automatically they are laden with triglycerides. And if we talk about remnant IDL, because this remnant IDL will actually be later forming what? LDL. So automatically cholesterol will increase. So these are what? These are hyperlipoproteinemias. Type 1, type 2A, type 3. Type 2A is autosomal dominant. So we can say that familial hypercholesterolemia is autosomal dominant in nature. Then after this, then we come over to hypolipoproteinemias. Lipoproteinemias. Right. So here basically we study two. One is Tangier's disease. Right. And second is 𝗵𝗵𝗵𝗺 lipoproteinemia. Now see, first of all we are going to study this Tanger's disease. Now, what happens in this Tanger's disease? There is a defect in ABCA1 gene. Defect is there in ABCA1 gene. Right. What is this ABCA1 gene? Simple concept is there. This is required for the transport of cholesterol as an ester from the peripheral organs required for the transport of cholesterol as an ester from the peripheral organs to form HDL. Right. That means if I say there is a defect in that, say this is your adipose tissue, or I would say peripheral organ. Right. And this gene ABCA1, यहाँ से this HDL is coming, which is actually discoid, and this discoidal, when LCAT enzyme or ACAT enzyme combined together, it is converted into spherical HDL. Okay, so if there is a defect in this, so automatically there will be a decrease in the HDL transport. Right. So what happens here is, what will be the features? If we talk about the features here, the most important feature will be our tonsils. Their color will change and we will have orangish tonsils. That is why maybe the name of the disease is Tanger's. Tang, which is very sour to taste, just like that. I'll just show you the picture also. So first of all, we can say that what are the features? Features will be orangish colored tonsils. Right. There will be hepatosplenomegaly also, and there will be neurological manifestations. Peripheral neuropathy is also observed. Okay, this is Tanger's disease. I'll just show you the picture what happens in Tanger's disease. And this is a very important question which has been asked in the exam so many times. So this is a characteristic feature of Tanger's disease. As you can see, the inflammation in the tonsils. Then after Tanger's disease, then the last one is 𝗵𝗵𝗺lipoproteinemia. It is clear from the word itself, A means without. That means no beta lipoproteinemias will be there. No beta. I've already told you pre-beta, broad beta and beta. So what happens in this? What is the cause behind that? So the defect is in the MTTP gene. MTTP gene. And this is actually microsomal triglyceride transfer protein. This stands for microsomal triglyceride transfer protein gene. and we know that this is the gene which is actually transferring all the VLDL and chylomicrons. So what will happen is, initially if we say that there will be decreased VLDL, there will be decreased chylomicrons, right. If there is decreased VLDL, it will lead to decreased LDL, decreased IDL. Everything will decrease. So what are the repercussions of that? What will be the features? Now, if we talk about the features, we all know that whenever there is decreased concentration of chylomicrons, if we talk about the fat-soluble vitamins, fat-soluble vitamins are actually transported in the form of chylomicrons. That is the main difference between water-soluble and fat-soluble. So, when the chylomicrons itself is low, the protein which is required for their transport is not there. So, their concentration will also decrease. So, features में the most important one will be, there will be, you can say, deficiency of the transporter, or you can say fat soluble vitamins will be affected. Fat soluble vitamins transport will be affected. And the child who is born with this will have difficulty in feeding. So, feeding difficulties will also be there. It might lead to bleeding manifestations also, because again vitamin K, bleeding manifestations, because the transporters are absent. Then acanthocytes, right, and it will be difficult to survive. Difficulty in surviving. So, automatically 𝗵𝗵𝗵𝗺 will lead to, it might lead to the death of the infant also, because the entire metabolism will be defective, right. So, this is what this is, these are the different type of, this is a Frederick classification of the different type of lipoproteinemias. I'll just show you certain tables so that you are going to remember this, because this is a very, very important topic which is actually asked in the exam so many times, right. So, this is just a summary. So, first of all, let's take this table. If LPL is defective, lipoprotein lipase is defective, or reduced level of LPL is there, it leads to pancreatitis. Same is the case when Apo C-II is defective. Okay, this is nothing but this is type 1 hyperlipoproteinemia. Okay, if we talk about 𝗵𝗵𝗵𝗺lipoproteinemia, obviously inability to synthesize everything in fact. So, there are neurological defects. Okay, then look at this table. If we talk about this table, this is type 2A. Type 2A is actually very important, right. Type 2A mein you have to just focus on one thing, that familial hypercholesterolemia is there, which is autosomal dominant, and defect is in the LDL receptor. This you have to remember. Baki rest others are also there, we can just go through this. So, type 2A में ही एक आता है familial defective Apo B, और it is autosomal dominant hypercholesterolemia, or type 2 where Apo B100 is defective. Again, if we talk about Apo B100, it is the receptor for LDL. So, you can say again it is autosomal dominant. Then again in this ADH type 2, 𝗵𝗵𝗃9 is there, which is defective. This is a protein which is targeting them to the lysosomes. Again, it is autosomal dominant. And type 2B is familial combined hyperlipidemia, where it is autosomal recessive, where LDL and VLDL both will increase. Okay, so this table is very important. This table you can omit also. So I'll just delete this table. This table is important. So we can keep this table because this we have already discussed. And then this is the table which actually compares the different type of lipoproteinemias. Here you can say that is what we discussed, type 1. Now whatever we discussed, it's the summary of that. Type 1 में increased lipoprotein, mainly it is chylomicron, then VLDL. Increased plasma lipid, that's what I told you, there is a difference, TGs are there. Why? Because LPL is deficient. Risk of atherosclerosis may increase but very rare. So what is the treatment? Low fat diet, because chylomicrons are responsible for the transport of exogenous or the dietary TGs. If we talk about type 2A, LDL, lipoprotein increases and cholesterol increases. Defect is due to the LDL receptors. Chances of CADs are very high because LDL, deposition of cholesterol in the heart, in the adipose tissue, and low cholesterol fat diet is the treatment. Type 2B, जिसमें LDL and VLDL both will increase. So obviously TGs and cholesterol will increase. Reason is overproduction of Apo B. Chances are very high. So again we prescribe low cholesterol diet. Then comes type 3, which is remnant removal disease, mainly remnant VLDL, or we can call them IDL. Okay, TGs and cholesterol, because I told you chylomicrons, remnant and remnant VLDL is going to increase. So, and what is the defect? There is abnormality, or you can say Apo E, which is required for receptor mediated endocytosis, is absent. Then very high, it will be very high, and low fat and low calorie diet or 𝗲𝗵𝗵𝗺 is the medicine required for this. Then comes type 4 and type 5. Type 4 में increased lipoprotein is VLDL, increased plasma lipid is TGs, there is overproduction of TGs. Or type 5 में the molecular defect is still unknown, risk is still unknown, and subjective, but it is not properly studied. But the most important one which you have to study is type 1, type 2 and type 3. So these are the different type of hyperlipoproteinemias. And if we talk about the hypolipoproteinemias, we have studied 2 types of this. And what are those? One is Tanger's disease. Tanger's disease ke liye I have told you how to remember it, Tang. So since Tang is like SAR, so Tanger's disease mein orangish tonsils will be there. Orangish tonsils. And second is A-beta lipoproteinemia. If we talk about the cause here, Tanger's disease mein there is defect in ABCA1, and here there is a defect in MTTPG. Okay, so this is the different type of dyslipidemias. Very, very important. Clinically also this topic is very important. So I hope this video is clear to all of you. Alright, so this is all in this. Thank you so much.